Okay, Priyak.
Hi, sir.
Hi, how are you?
I'm good. What about you, sir?
Fine, thank you. And how is the rains in Surat? Kerala is having such torrential rain that a good part of the state is underwater now. Torrential rain.
Oh, till today we didn't have the rain in the past days, but today we have a heavy rain, sir.
Hmm. Kerala is experiencing an exceptionally heavy rain, torrential rain continuously. Okay. Anyhow, we'll go to the session.
Sure, sir.
Good evening, students. We'll initiate the session. Today we will have some spot tests and also some discussions about some basic things. So I need volunteers to answer the questions. Spot tests will be mostly electrocardiogram and hemodynamic data and X-ray test. We will also touch upon some of the basic things like afterload, wall stress, and how to define and how to what are the factors which influence the wall stress. So we'll go to the I'll share the screen first. Okay, can you see my screen? Is it visible to you?
Yes, sir.
Okay. So we'll start with the first session. What do you mean by contractility and how do you measure contractility? And how is contractility different from force of contraction? Anyone of you can answer?
Measurement is by dp by dt.
Very good. dp by dt is the measurement of contractility. Define contractility. What is your name?
Ranjit.
Eh?
Ranjit.
Ranjit. Okay. Okay, Ranjit. What is? You are from Trishur Medical College?
No, sir. General Hospital, Ernakulam.
General Hospital. Okay. What do you mean by? Can you define contractility?
The rate at which the force buildups in the myocardium.
No. That is not contractility. Your other answer is correct. Contractility is measured by measuring dp or dt. What is meant by contractility, and how is it different from force of contraction?
Don't know.
Okay. Anybody who would like to define contractility? That's not a problem because contractility is something which you must know. This is a basic thing, and anybody? Contractility is defined as the intrinsic property of the myocardium to contract, independent of the loading conditions. That's the most important thing. Loading conditions can always influence the force of contraction of the myocardium. Preload. If there is an increase in preload, according to Starling's law, the force of contraction can increase. If there is an afterload reduction, the myocardium can perform better and empty its contents better. But contractility is something which is the intrinsic property of the myocardium to contract independent of the loading conditions. And it is the inotropic agents are the ones which increase the contractility. And the contractility is measured by dp or dt. What is afterload? This is a much simpler question. What is afterload? What is meant by afterload? Anybody who would like to address this question? What is meant by afterload? There must be. Okay, what is meant by afterload? Afterload is the resistance against which the ventricle pumps the blood. So if in the left ventricle, it starts with, just a minute. Okay, the afterload is the resistance against which left ventricle or the right ventricle pumps the blood. Mostly it is the left ventricle afterload. But if you want to extend it to right ventricle, it can also be included. The afterload starts from the outflow region. So if there is an outflow obstruction, that will add to the afterload. Then there is the vascular resistance, the compliance of the blood vessel or the resistance offered by the blood vessels, the resistance offered by the blood, the viscosity of the blood, all contribute to the afterload. So afterload is the resistance against which the left ventricle or the right ventricle, the ventricles pump the blood. What is afterload mismatch and what is the importance? What do you mean by afterload mismatch? Any one of you? And what is the importance of this afterload mismatch? Ranjit, would you like to try? Vineet?
It is seen in aortic stenosis.
Yeah. Stenosis is not the only condition where you can have this. So first you should define what is afterload mismatch.
Not aware.
Any one of you would like to try what is meant by an afterload mismatch? When there is an increase in afterload, what will happen to the left ventricle?
Hypertrophy, concentration.
Yes, it can hypertrophy. Well, very good. There is a compensatory mechanism. Why? When does this? What is the relevance of afterload mismatch? When there is an afterload mismatch, significant afterload mismatch, LV fails to pump the adequate quantity of blood. It can lead to heart failure. We'll quote an example, then becomes more clear for you. Afterload mismatch is the inability of the ventricle functioning at a stable level of inotropic state to maintain normal stroke volume against the altered afterload. If there is a sudden change in the afterload, the ventricle may find it difficult to pump the blood, and it may not be able to pump adequate quantity of blood. That is what is meant by afterload mismatch. Afterload mismatch is the inability of the ventricle functioning at a stable level of inotropic state to maintain normal stroke volume against the altered afterload. Best example of an afterload mismatch is an acute systolic loading of the ventricle in acute hypertension. If there is an acute rise in the blood pressure, there can be an afterload mismatch. The left ventricle will develop pump failure without myocardial dysfunction. Most important thing is that all the parameters of myocardial function, the contractility, every parameter of the myocardial function is still maintained, but the only thing which has changed is actually an afterload. When there was a sudden change in the afterload, which has resulted in a mismatch, will result in pump failure. So afterload mismatch is the inability of the ventricle functioning at a stable level of inotropic state to maintain normal stroke volume against the altered afterload. Example, acute systolic loading of the ventricle in acute hypertension can lead to LV pump failure without myocardial dysfunction. Another important situation where, can anybody mention another important situation where there can be an afterload mismatch? In a patient with mitral regurgitation, when they undergo mitral valve replacement, following mitral valve replacement, there can be a sudden afterload mismatch. Why it is so? Any one of you? In a patient with mitral regurgitation after valve replacement, the patient can suddenly go in for afterload mismatch.
In a patient with mitral regurgitation, LV was decompressing through the mitral valve. Once the MVR is done, then LV is unable to decompress via the mitral valve. It has to pump through the aortic valve only.
So there is a sudden increase in the afterload. So in a patient with mitral regurgitation, when the patient is having the lesion, the LV is able to pump blood into the left ventricle, left atrium, which is a low pressure zone, and onto the aorta also. So the LV was working against a very low afterload. But when the mitral valve is replaced, the mitral regurgitation is over, and the LV has to pump or the whole quantity of blood into the aorta, which is a high pressure zone. So there will be an acute rise in the afterload. And some of this, if there is the LV is not able to sustain good cardiac output, then we call it an afterload mismatch. Sometimes patients with aortic stenosis, especially patients with aortic stenosis with a small aortic annulus, when they undergo valve replacement, there can be an afterload mismatch. That is because these patients can have a iatrogenic aortic stenosis because of the mitral aortic annulus is narrow, small, hence the prosthetic valve itself behaves like a stenotic valve. And some of these patients can be, the stenosis can be, the gradient can be so significant that there is something known as afterload mismatch. So in patients with aortic stenosis, especially with a small aortic annulus, when they undergo valve replacement, that can result in an afterload mismatch. So these are the few situations where there can be an afterload mismatch. Out of it, the most frequent situation where we come across an afterload mismatch is acute rise in the systemic blood pressure, resulting in acute left heart failure. Afterload mismatch occurs when the preload reserve is unable to compensate. What usually happens when there is an increase in the afterload is that there is an increase in the preload, because initially there is a reduced stroke volume. When there is a reduced stroke volume, that will result in increase in the end systolic pressure. That can result in increase in the end diastolic pressure. So when there is an increase in the end diastolic pressure, that will compensate, because the increase in the end diastolic pressure, that is the preload, will increase the force of contraction of the myocardium, and that will compensate for the afterload increase. So when there is an afterload increase, there is an increase in the preload, and that will result in the increase in the force of contraction. So, but in patients with afterload mismatch, this compensatory mechanism will not be able to function properly, or it may not be enough to compensate the acute rise in the afterload, and the patient goes in for an afterload mismatch. You must definitely know the term afterload mismatch and what is meant by afterload mismatch. We'll go to another important basic thing in cardiology, that is about the wall stress. What is wall stress? What are the factors which can modify wall stress? Anybody? What is wall stress? And what are the factors which can modify wall stress? These are all interrelated. Afterload, wall stress, all these are interrelated. And also you should know what are the factors which modify the wall stress.
Cavity and the thickness of the cavity of the chamber, diameter of the chamber,
So radius, rather radius,
and yes,
radius of the chamber.
And thickness of the chamber.
Yes, thickness of the
will-
myocardium. And one more point. And afterload.
Yes.
Afterload, the radius of the LV, which is the chamber involved in wall stress, and third is the thickness of the myocardium. So, and how does this define wall stress? What is wall stress? Any one of you, can you define wall stress? Wall stress, it is the load on per unit of myocardium during systole. It is a wall stress you should understand is defined as the load on per unit of myocardium during systole. Wall stress is modified by afterload, LV chamber radius, and the heart muscle thickness. Applying the Laplace equation, wall stress is equal to afterload into radius divided by the thickness. So the afterload as well as the radius increases the wall stress, while the thickness which reduces the wall stress. So the thickening of the myocardium in a patient with an increased afterload is a compensatory mechanism. So in a patient with systemic hypertension or a patient with pulmonary aortic stenosis, there will be LV hypertrophy, which is a compensatory mechanism. It helps to bring down the wall stress, normalizes the wall stress. If the patient continues to have wall stress, gradually the myocardium will fail and they may not be able to perform properly. So the hypertrophy is a compensatory mechanism by means of which myocardium normalizes the wall stress. The wall stress is the load on per unit of myocardium during systole. Wall stress is modified by afterload, LV chamber radius, and heart muscle thickness. Applying the Laplace equation, wall stress is proportional to the afterload and the radius and inversely proportional to the thickness of the myocardium. Okay, now we'll go to an electrocardiogram, and any volunteers to discuss the electrocardiogram? There should be volunteers to discuss the electrocardiogram. Anybody can try. You. Okay, what does the electrocardiogram show? Is the patient in normal sinus rhythm? Describe the P waves. What is the axis? Any abnormality in the QRS complex? I'm surprised that the final year DM students are not able to analyze this. This is a very simple ECG.
Right axis deviation.
Yeah, right axis deviation, very good.
There is left atrium enlargement and RVH.
So there's left atrial enlargement and RVH. Is there a right atrial enlargement?
No, sir.
Borderline, if at all. Okay, so there's left atrial enlargement in the right ventricular hypertrophy. When this combination comes, why did you diagnose left atrial enlargement in this patient?
The terminal portion of the P wave is more than 1 millimeter in depth in V1.
Okay, not 1 millimeter in depth is not enough. Actually, What is the definition of a left atrial or left atrial overload or left atrial enlargement in the P wave in V1?
More than 0.04 millimeter second.
No, 0.003.
Okay.
More than 0.003 millivolts second. Not millimeter, millivolts second. So if you want to say millimeter, okay, then you are saying that this is one small square. But correct definition is the negative part of the P wave in V1 should be more than 0.003 millivolt seconds. So if it is equal to one small square, then you can take it as left atrial overload. Here it is more than one small square. So I agree with you. That is left atrial enlargement or left atrial overload. Okay, then what else? Why did you diagnose RVH?
The amplitude of R wave in V1 is 7 millimeter.
Yes, there is a QR pattern in V1 with a small Q with a R pattern. There is no S wave at all. That's okay. And R by S is the criteria applied for diagnosing right ventricular hypertrophy. Yes, what else? See, is this patient having? Do you want to modify the RVH? I would like to say that the RVH with strain with STT changes.
Yes, sir. RVH with strain.
So what does that mean?
Systemic RVH.
Yes, suprasystemic. When there's the RVH with especially QR pattern with the STT changes suggest your strain pattern, then you have to consider that the patient may be having suprasystemic pulmonary artery pressure. So what is the condition in which you can get this combination of left atrial enlargement with the right ventricular hypertrophy? What is the condition, clinical condition, where this combination is possible? That is a very simple question. You must be seeing plenty of such cases. Any one of you? This combination of left atrial enlargement with right ventricular hypertrophy. Oh, I'm surprised.
DRB is restricted.
Yes, mitral stenosis. In patients with mitral stenosis, when they develop pulmonary arterial hypertension, then the electrocardiogram will show left atrial enlargement because of the dilated left atrium and pulmonary arterial hypertension resulting in right ventricular hypertrophy. So they can have left atrial enlargement with right ventricular hypertrophy. When you see this combination, almost always you should think of the possibility of mitral stenosis. Okay, this is slightly more difficult electrocardiogram. This is an arrhythmia, not a usual arrhythmia, an unusual arrhythmia. Any volunteers to discuss? I will help you. This is a monitoring lead.
Sir, rhythm strip is showing atrial rate of 74 beats per minute.
Okay.
With the ventricular rate of 80 beats per minute, sir. With the intermittent conduction of atrial to ventricular conduction.
Okay. So atrial rate is around 74, 75 and
yes,
ventricular rate is around 80, 81.
Yes.
So what is the abnormality? Is it an abnormality in impulse formation or abnormality in impulse conduction?
Abnormality in impulse formation, sir.
Yes, impulse formation. Whenever the rate is when the lower rate is more than the upper rate, the rate of the atrium is less than that of the low ventricular rate, then you consider it as an abnormality in impulse formation. If there is a atrial rate is more than the ventricular rate, that is an abnormality in impulse
conduction.
So here there is the atrial rate is the atrial rate is less than the ventricular rate, indicating that this is an abnormality in impulse formation. Now, what is arrhythmia? As you rightly said, intermittently the P wave is capturing the ventricular activity. The sinus beat is capturing the ventricular activity. So, what is this arrhythmia? What is the rate is only around, not a very fast rate, the rate is only around 80, 84, 82.
Sir, a junctional ectopic activity.
No, junctional rhythm. It is a junctional rhythm with intermittent. What is this? What is this
Atrial,
beat?
yes, sir, atrial capture,
It's not an atrial capture, sinus capture.
sinus capture.
There's a basic junctional rhythm with a sinus capture. Junctional rate is 80, 82. Is it the normal junctional rate or is it a faster rate?
Faster, sir.
Faster.
Accelerated junctional, the more
Yes.
than 60.
More than 60 is a faster rate. So it is a junctional tachycardia.
Yes, sir.
But the rate is only 80. For us to call it as a tachycardia, very often we expect the rate to be more than 100. So what time can you give? When the rate is more than the standard rate of the junction, but at the same time we cannot qualify it as tachycardia. What can be the term that you can apply?
Accelerated junctional rate.
Very good. Accelerated junctional rhythm
Yes.
with intermittent sinus capture. That's the diagnosis. So usually the accelerated junctional rhythm will have a rate of around less than 100, usually between 60 to 100. And this can happen associated with a pathology in the heart where the junction is stimulated and it starts firing at a faster rate. It is a accelerated junctional rhythm with intermittent sinus capture. A very rare ECG. I don't think you would have seen one of this kind. It's an extremely rare ECG. Okay, this is simpler. Any volunteers? Look at the electrocardiogram well. Then once you have got some idea, you can start talking.
Sinus rhythm,
Sinus rhythm, very good.
PR of
We cannot actually call it sinus rhythm actually because the PR is
240 to 280 milliseconds.
Yeah, it is how many divisions?
6, 7.
7 or 7.5. So almost 300 150 milliseconds.
Yes.
No, 150, not 150. 0.4 into 300
280
milliseconds.
milliseconds.
300 milliseconds. Okay. Yes.
RSR pattern with QRS duration of 1.
Yes.
120
duration. It's more 3 divisions. So it is indicative of a broad QRS complex.
QRS.
Is it what are the causes of broad QRS complex?
Bundle branch block.
One branch block.
Aberrancy.
Aberrancy bundle branch block both together. The same thing.
Pre-excitation. Pre-excitation.
Pre-excitation, very good. WPW, pre-excitation. Ventricular focus.
Ventricular ectopics.
Ventricular focus. And finally,
Sinus rhythm. Then
any electrolyte imbalance?
hyperkalemia.
Hyperkalemia. So these are the 4 important reasons for a broad QRS complex. Previously, when we used to use class 1 antiarrhythmics, especially quinidine, sometimes quinidine can give rise to broadening of the QRS complex. But nowadays, quinidine is not in use and you don't see that. So, but you can mention some of the drugs like quinidine can also prolong the QRS duration. So, out of these 4 conditions that you described, what is the cause of the broadening of the QRS complex in this patient?
Bundle branch block. Right bundle branch block.
Which one? Right bundle, left bundle?
Right bundle branch block.
Right bundle branch block. So this patient is having right bundle branch block, first degree heart block. And what is the QRS axis?
There, plus 120 degrees.
Is it plus or is it minus?
Plus only,
So,
sir.
all the limb leads are almost isoelectric, sir. Like,
Yeah.
one,
If at all, but lead 3 is
No, lead 3 is
positive.
significantly more
totally
positive.
positive. AVR also is positive.
AV, sir, AV.
Not AVR, not AVR, AVF.
Yes, sir. AVF is positive.
So all put together, I would start thinking that the axis more towards the right than onto the left.
Yeah. Right axis.
So there is right axis deviation. Axis may be around 120 or 140, 150, 120 would be more correct. So a patient has got an QRS axis of 120 and first degree heart block, and also having a right bundle branch block pattern. So all put together, what is your diagnosis?
Trifascicular block.
Trifascicular block. Why the patient is having a right axis deviation?
Left posterior hemiblock.
Left posterior block. Yes, very good. What is your name? What is your name?
Ranjit.
Eh?
Ranjit.
Ranjit.
Yes.
Oh, right. Are you final year student or a second year?
Final year, sir.
Final year. Okay, very good. I think you are gaining confidence. Very good. Okay. What is this electro? You have to see from one end to the other end. What is this electro? What does this electrocardiogram show?
Sir, 2:1 AV conduction, sir.
Eh? Why did you say 2:1 AV conduction?
Because if we see at 1, 2, 3, 4, 5, fifth beat, sir, from fifth beat onwards, that at the end of P wave, 1 P wave was there. And again, next beat also at the end of T wave 1 P. And next beat also again at the end of T wave 1 P.
You are mostly right. You can see two P waves. One is a P wave. This is a P wave. And you can see, let me see. This is a P wave, and here is another P wave. Here is a P wave. Here is another P wave. But this is a P wave. Here is another P wave. But your statement that is 2:1 conduction may not be always correct, because what is happening to this PR interval is becoming shorter and shorter, and it has gone through it.
Yes. Yes. Yes, sir. Yes, sir. Yes, sir.
So what do you think it is?
Isorhythmic AV dissociation.
No. In the isorhythmic AV dissociation, you can have only one P wave. Here it is, there are two P waves. So can this be a complete heart block?
Probably, sir.
How will you diagnose complete heart block?
Yes,
Criteria?
sir.
Criteria?
PP interval should be equal and RR interval should be equal.
Very good.
And AV dissociation should be there.
Very good. PR interval should go on changing. Yes. And one more point. P rate will be?
V rate will be less than atrial rates.
Or rather P will be more than QRS complex. So if all the criteria are satisfied, if you look at the RR interval, then PP interval, and then look at all the, so there is some AV dissociation because the PA is marching through the QRS complex. And it just, it has come out to the T wave here. You can see the P wave very well here. Its P wave is here. And then what has happened subsequently?
Sinus conduction.
Yeah, there is a conduction, it's a conducted beat. This becomes a normally conducted beat. And what is seen in the electrocardiogram? What does it? It is a lead to showing ST
Elevation.
elevation. So what is the diagnosis?
Lead to inferior wall.
Yes, the patient is having inferior myocardial infarction, transient complete heart block with the ventricular rate is adequate, because here the rate is around. If you look at the rate, look at here, 1, 2, 3, 4, 5, 5.5. Almost between 50 to 60 would be the heart rate. So adequate rate with the complete heart block, and the patient quickly recovered, and the patient is having inferior wall myocardial infarction. And when it recovered, even the first degree heart block recovered. The patient is having a normal PR. So during the acute phase, they can have a different arrhythmias, and they can even quickly recover, especially inferior myocardial infarction. This AV block can be even transient and they can quickly recover. Okay, what is this? What is this electrocardiogram? What does this electrocardiogram show? This is electrocardiogram of a 3-month-old baby.
Sir, sinus rhythm.
Okay, sinus rhythm.
Normal sinus rhythm, sir, with AVL axis around plus 60 degrees.
Okay.
With RVH plus LVH.
Yeah.
Sir.
Okay. Whenever you see this type of a large equibasic deflections in the mid-precordial leads, what is that phenomenon known as? Katz-Wachtel phenomenon. What is the criteria for diagnosing biventricular hypertrophy based on the Katz-Wachtel phenomenon like electrocardiogram?
More than 50 millimeter amplitude.
More than 45. More than 45. More than the R and S put together should be equal to or more than 45. Here it is just short of that, but for all practical purposes, we can take it as a Katz-Wachtel phenomenon. And what is the diagnosis? What is the lesion that you are going to diagnose by you find by the Katz-Wachtel phenomenon?
Non-restrictive VSD.
Non-restrictive VSD. Usually it is a large VSD that can give rise to Katz-Wachtel phenomenon. And in a VSD, what is the type of ventricular involvement? What type of ventricular involvement is there? How is the LV involved? How is the RV involved?
Sir, LV volume overload will be same.
Yes, LV will be volume overload and RV will be a?
RV will be normal.
Normal.
Pressure.
What will be the LV will be volume overloaded and RV will be pressure overloaded. When the LV is pumping the blood into the RV and from there it is ejected into the pulmonary artery. When large volume of blood is being pumped into pulmonary artery, the patients can develop progressive pulmonary arterial hypertension, and that can result in right ventricular hypertrophy, pressure overload.
Sir,
left ventricular will be volume overload.
Yes, sir.
Beg your pardon?
Sir, textbook description will be to develop RVH. RV will be decompressing into LV, no, sir. So there won't be any RV hypertrophy.
How can RV decompress into LV?
When the pulmonary pressures increases. So,
oh, that means they have developed Eisenmenger syndrome. Oh, that will be too very late. But before that, there is a progressive increase in the pulmonary artery pressure, and the RV has to pump against the elevated pulmonary artery pressure. They are progressively going for right ventricular hypertrophy.
yes.
So, if you look at the involvement of the RV and LV in a large VSD, it is the volume overloaded. The LV will be volume overloaded, and RV will be pressure overloaded.
Okay. In large VSD also, sir?
A large VSD. Moderate to large VSD. In moderate VSD also, high moderate VSD also, you can get the same phenomenon. When the VSD is very small, there may not be any change at all. Because the volume of the blood may not be enough to produce neither the volume overload nor the pressure overload secondary to pulmonary arterial hypertension.
Okay.
Okay, what is this?
Sir, normal sinus rhythm.
Very good.
ST coving in lead 1 and
whenever there is ST going in lead 1, what is other lead you should quickly look for? Any coving?
AVL. Sir.
AVL. So AVL also shows some degree of coving.
I am unable to see, sir.
Yes, there is some degree of coving.
Yes,
it's more pronounced
and,
in lead 1.
yes.
Then what
And
happens?
just the elevations in V1 to V6, sir,
Yeah.
with poor R progression.
Yes, not poor. There are Q waves. Why did you say poor R progression? There is actually V1 to V2. V2 is very rudimentary, almost Q waves. And V3, V4, V5, V3 and V4 there are Q waves. So even practically or for practical purposes, V2 also can be taken as a QS pattern. What else? What happened? What happens to here? PR segment.
Acute pericarditis, PR segment depression.
Yes, you can see the PR segment depression suggestive of pericarditis. So the full diagnosis in this patient would be acute anterior myocardial infarction
Associated with acute pericarditis.
associated with
Acute
pericarditis.
pericarditis.
Very good. What does the electrocardiogram show?
Suprahischian complete heart block.
Yeah, very good. Suprahischian complete heart block. So why did you diagnose suprahischian complete heart block, and how do you differentiate suprahischian from infrahischian complete heart block?
QRS bit is less than 120 milliseconds in suprahischian. If it's
Yes.
wide, it's infrahischian.
Yes, very good. The broad QRS complex goes with infrahischian complete heart block, while suprahischian usually is associated with narrow QRS complex. Okay, right? Yes. When you do if you do a bundle of electrogram, what will be the pattern?
In suprahischian, there won't be a H interval, there won't be H wave. Infrahischian, there won't be a V wave after H.
No, no. When the H goes with atrial wave, if the H goes with atrial wave, H goes with A, it is a
Infrahischian.
infrahischian, and if the H goes with V, it is a suprahischian. So that is how you differentiate. If when you record the bundle of electrogram, if the bundle of electrogram goes with the atrial tracing, that it is an infrahischian complete heart block. And if the H wave, the bundle of tracing goes with the ventricular tracing, then it is a suprahischian complete heart block. So here it is obvious because the patient is having a narrow QRS complex, and you can easily make out that this is a suprahischian complete heart block. Right. Okay. Very good. Look at the electrocardiogram and tell me your diagnosis.
Broad complex tachycardia
Broad QRS complex tachycardia. Very good.
with AV dissociation.
Why did you say
Captured with-
dissociation? Are you able to make out P waves?
P waves. No, sir.
Atrial fibrillation.
Atrial fibrillation with
Pre-existing LVDB.
Very good. Atrial fibrillation, because you are not able to distinctly see periods. There is a QRS is irregular, and there is a broad QRS complex. So patient is having a atrial fibrillation with pre-existing
LVBB.
LV left bundle branch block. So it's a atrial fibrillation in a patient with pre-existing left bundle branch block. This is slightly more difficult ECG.
Hey.
Yes.
With atrial flutter with varying block.
Yes, there is a atrial flutter. Is it flutter or fibrillation?
Flutter
Forced
fibrillation.
fibrillary waves.
Force atrial fibrillation. It is not flutter because flutter waves will not vary in morphology. Here, the waves are from one wave to another wave, it is varying in morphology. So when the waves are varying in morphology, you must always consider it as fibrillation. And some of the waves are really coarse, large waves, so indicating that this could be a coarse atrial fibrillation. Okay. All right,
There
coarse
is
atrial fibrillation.
U wave also.
So there's a prominent U wave. What about the RR interval? Is it regular or irregular?
CHP.
GHP.
Yes, RR interval is
Regular.
regular, indicating that patient is an associated complete heart block in a patient with atrial fibrillation. When the ventricular rate is irregular, you have to consider that the patient has got a complete heart block and the ventricle is controlled by a lower focus, maybe at the junction or maybe at the ventricle. Okay, right? Yes. Here it is at the junction because there is narrow QRS complex. So you also found that patient is having a prominent U wave. What else?
There is a biphasic T in V3.
It could be a partly from the part of it may be U wave. The U wave may be prominent. When will you say that U wave is abnormal?
If it's more than the amplitude of T wave,
No, it may not be more than the amplitude of T. What is the normal amplitude of the? What is the relationship of U wave to the T amplitude?
less than 1/4.
Less than 1/4. More to be more precise and correct, 5 to 15%. The height of the U wave is equal to 5 to 15% the height of the T wave. At what level will you consider that U wave is abnormal?
More than 25% of T
More
wave.
than 50%. When the QRS, when the T wave is equal to or more than 50% the size of the U wave, you can when the U wave is more than 50% the size of the T wave, you can definitely say that it is a abnormal U wave. So here this patient is having an abnormal U wave. Yes. What is the condition in which you can get the prominent U wave?
Hypokalemia.
Hypokalemia. Hypokalemia is the commonest condition where you can get a prominent U wave. So this patient is having a prominent U wave. And what else? Without this complete heart block, atrial fibrillation. Any chamber hypertrophy?
Papillary muscle hypertrophy.
No, sir.
In V4 R wave is 1, 2, 3, 4, almost 25, 23 divisions. And what is the V1 S wave?
Um,
1, 2, 3.
yes,
15.
sir.
Yeah, what is the-
It will be more than 30.
Yeah, it's equal to or more than 35, maybe with what 36 or 37, indicating that the patient is having
Left ventricle.
LVH by voltage criteria. So, what are the things that you can deduct? This patient is having a atrial fibrillation, complete heart block, then prominent U waves. Patient is having coarse atrial fibrillation, and LVH. So, what are the conclusions that you can conclude?
Restrictive cardiomyopathy.
Eh?
Restrictive cardiomyopathy.
Okay, it can be a cardiomyopathy type of a picture, yes. But usually the atrial fibrillation in cardiomyopathy, is it a coarse atrial fibrillation or a fine one?
Fine, because the LA will be damaged.
Yeah, usually it is in atrial fibrillation in a patient with dilated cardiomyopathy usually will be a fine atrial fibrillation. What are the situations where you can get a coarse atrial fibrillation?
New onset atrial fibrillation.
To a large extent, new onset atrial fibrillation can be a little more coarse than late one because over a period of time the atrial fibrillation becomes fine. But coarse atrial fibrillation is mostly usually associated with valve lesions, especially mitral valve regurgitation, mitral stenosis. Valve lesions which progressively develop into atrial fibrillation have got a very coarse atrial fibrillation. So this patient is having a coarse atrial fibrillation. The patient is having a complete heart block. Patient is having LVH. Patient is having prominent UVs. All put together, what will be your diagnosis?
Patient may be in heart failure and patient is on diuretics.
Yes.
So hypokalemia may be drug induced.
Very good. One is hyperkalemia, may be drug induced. Two. What else? What may be the reason for this patient? Do you think that this can be digitalized toxicity?
Yes, sir.
Yeah, because this patient is having atrial fibrillation, the patient might have been put on digitalis, and the patient might have gone in for digitalis toxicity. So a full diagnosis will be most likely the patient is having, of course, the patient is having atrial fibrillation, complete heart block, LVH by electrocardiogram criteria, and and prominent UVs. All this indicating that prominent UVs indicate hypokalemia, and the LVH may indicate mitral regurgitation. Patient is having atrial fibrillation, and complete heart block is also due to digitalis toxicity, digitalis side effect. So the full diagnosis would be atrial fibrillation, complete heart block, LVH, hypokalemia.
Probably digitalis toxicity.
Most likely there is digitalis toxicity. Because we do not know whether the patient has received digitalis, but looking at the setup and the criteria, you can diagnose associated digitalis toxicity. Okay, very good. Next one. There are two gaps. You should explain why there is a gap. What is the reason for a gap?
exit block.
Yes, what block?
Sinus exit block.
No, it is not sinus exit block. No, wrong. You can see two negative waves here. One is here and one is here.
Yes.
What do you think that wave is? Is it a P wave? If it is a P wave,
Ectopic.
yeah, it's an
Low atrial
yeah, it's an ectopic P wave. And what has happened here?
Compensatory pause.
Yeah, there's a pause. What has this P wave done?
Block the AV conduction.
That's not block the AV conduction. They are blocked atrial ectopics. This is a blocked atrial. This is a blocked atrial ectopic. This is a blocked atrial ectopic. What do you mean by that? There is an atrial ectopic which is quite early. See, you can see that it's very early. When there is a very early ectopic beat, when the beat reaches the AV node, it may find the AV node is refractory and it's not able to penetrate the AV node because it is refractory because of the previous beat. It is already in the stage of refractory period, and the impulse cannot be conducted through the AV node. So when the impulse is not being conducted through the AV node, then we call it as blocked atrial ectopics. But what can it do? It can travel upwards, it can depolarize the atrium, and also it can depolarize the sinus node. Thereby it is resetting the sinus node. It resets the sinus node, and that will result in a widened interval between the which encloses the blocked atrial ectopics. So the one which encloses the blocked atrial ectopic will have a broad QRS. Oh, sorry, a gap. So you can see that this is a blocked atrial ectopic and there is a gap. It's blocked atrial ectopic, there is a gap. And this blocked atrial ectopic traveled upwards, went into the sinus node, depolarized the sinus node, and has reset the sinus node. and when the next sinus beat comes, it comes with a delay. So this is a blocked atrial ectopics. Two blocked atrial ectopics are seen. That is the reason for this prolonged RR interval. Don't read it as a AV block. It is actually a blocked atrial ectopic. Okay, next one. It's slightly more difficult. Rhythm strip is lower down. You can see the two-lead electrocardiogram, and you can see the rhythm strip also. Any volunteers?
It's a high-grade AV block.
High-grade AV block. Very good. It's a high-grade AV block. There are 4 PVS followed by a QRS complex. Yes. One is a high-grade AV block. Yes. Is it a infraesian or a supraesian block?
QRF morphology is alternating in rhythm strip.
Yes.
QRF morphology is changing,
Yes.
but it's wide, so it's likely to be infraesian.
Yes, it is. Whenever you are seeing a high-grade AV block, 3 or more the PVS are dropped, then almost always it is a infraesian complete heart block. Don't go for anything else. Why it is so? Why it is so? When if it is an infraesian complete heart block, what will be the usual rate? Infraesian complete heart block rate?
Around 30 to 40.
Yes, usually below 40, 20 to 40. What will be the rate in a supraesian complete heart block?
40 to 50.
Yeah, the impulse is starting from the junction or it may from the AV node, and usually the rate will be between 40 to 60. So faster rate, they will have faster rate. So the AV node is the second pacemaker that we have, and whenever the sinus node is not able to control the ventricular rate, and when the ventricular rate falls below 60, the junction may escape, and you can capture the ventricular activity of the heart. So in a patient with a high-grade AV block, when the rate falls below 40, if it is a supraesian type of complete heart block, the junction should escape, and that can result in a normal ventricular complex. So whenever there is a high-grade AV block, which is quite prolonged, and the rate is very slow, then most likely it is an infraesian type of a complete infraesian block. Of course, here it is not difficulty because you can see that the QRS is broad. The QRS in V1 indicate the right bundle branch block. So obviously you can easily diagnose that it is the infraesian type of a high-grade AV block. Infraesian high-grade AV block. What is the how will you explain this change in the morphology of the QRS complex? Morphology of the QRS complex is going on changing. How will you give an explanation? And what is it? How can there be a variation in the morphology of the QRS complex in the limb leads?
Ventricular escape from different focus.
No, it is not ventricular focus. It is actually a supraventricular focus being conducted with a 4:1 block. See, whenever you get an RSRS pattern in V1, it usually does not indicate a ventricular origin. It usually indicates a right bundle branch block pattern. You can see here a RSRS pattern in V1. So obviously I will go for a conducted beat. This is a conducted beat. This is a conducted beat. You can see that there is a conducted beat here. Here I don't know what is happening, but it's a conducted beat. So whenever there is a conducted beat and the conducted beat has got an RSR pattern, it indicates bundle branch block pattern. Classically, it is the right bundle branch block pattern. How will you explain this? But in the limb lead, you are seeing a variation. Whenever there is a situation where the chest leads indicate either a right bundle branch block or a left bundle branch block, or it shows no bundle branch block at all, but the morphology of the QRS complex is going on changing in limb bleeds, you should think of the possibility of alternating anterior vesicular and posterior vesicular block. Whenever you see that the morphology of the QRS complex is going on changing in the limb leads, but not changing in the chest leads, then you should think of the possibility of a vesicular block. And here it is going on changing. So you can think of the possibility of alternating left anterior vesicular block and left posterior vesicular block. When there's a left anterior vesicular block, there will be left axis deviation, and when there's a left posterior hemi block, it will give rise to right axis deviation. So here you can see that this patient is having right bundle branch block, right axis deviation indicating right posterior vesicular block, left posterior vesicular block, and the patient is having a high grade atrial block. What will be the management?
Dual chamber
Temporary pacemaker.
Yeah, initially followed by
Rule out reversible causes.
unlikely, because this patient is having 4:1 block unless the patient is having an acute myocardial infarction. But here, all put together, and the patient is having a bundle branch block, all put together, most likely the patient is having
Degenerative.
chronic high grade AV block, and the patient will require a permanent pacemaker. Very good. Okay, we go to the exercises. Exercise volunteers.
Chest X-ray PA view.
Very good.
Adequate exposure.
Very good.
Properly positioned.
Yes.
There's cardiomegaly, cardiothoracic ratio of around 65 to 70%.
Yes, on visual assessment, you don't have to say 65 to 70%. Now you can say on visual assessment there is cardiac enlargement.
Yes.
If you want, you can use the word mild, moderate, severe. What do you think is cardiac enlargement? Is it a mild enlargement, moderate, or severe large enlargement?
Moderate.
Moderate. So mild to moderate at the most. Maybe the cardiothoracic ratio may be around 60%, near about 60%. Not a huge enlargement, but definitely there is a cardiac enlargement. Yes, what else?
It's an LV type of effects.
Why did you say LV type?
Because the it's an RV type effect.
I won't use the word either RV or LV, because RV means it should be lifted up, and LV means it should go below the diaphragm. It should be bending down.
Okay.
Both are not there, so I may not make a comment that I may not commit to any particular form of the LV, whether LV is forming the apex or the RV is forming the apex. Yes.
The straightening of left heart border.
Can you describe it? What are the structures from above downwards on the left border of the heart?
Aortic knuckle, pulmonary artery segment,
Yeah.
left atrial appendage.
Very good. And left atrial. Sometimes in between, just below the left atrial appendage, sometimes a part of the RV outflow can be seen sometimes, especially in patients with one condition where you can classically see RV outflow. What are the conditions which you can get from an RV outflow or RV outflow and RV outflow pulsations?
RVMF.
RVMF. Any other condition?
Abstain.
Abstain, very good. Abstain anomaly. And also you can get sometimes in AST also, when there is AST is very huge, especially which is associated with mitral stenosis. There can be torrential flow of blood into the through the ASD and to the right ventricle. Right ventricle will be significantly overloaded, and that can result in not only the body of the RV will be dilated, but the outflow also can be dilated. So sometimes you can get good pulsations of the RV outflow in a patient with ASD. And the RV outflow pulsations are felt in the third left intercostal space. And it in the X-ray chest, it can be seen just below the area of the left atrial appendage. Here, what is this? So structure that you see here, one is what is this structure? This is the aorta, and what is this structure?
Main pulmonary.
Very prominent pulmonary artery segment. In a patient, what are the conditions in which you can get prominent pulmonary artery segment? What are the conditions?
Pulmonary artery hypertension.
Increase in the pressure of
Pulmonary
pulmonary hypertension to
ASD, sir.
increase in flow, increase pulmonary blood flow. That can give rise to prominent pulmonary segment. 3,
TAPVC,
post-stenotic dilatation, and also it can sometimes idiopathic dilatation of the
idiopathic dilatation.
pulmonary. So in this patient, we are finding that the patient has got a prominent pulmonary segment. So we have to decide what may be the cause. Is it a pressure? Is it a volume overload? Or is it a combination?
It can be a combination. RA is also enlarged. So
RA is
can be
also enlarged. RA enlargement indicates that patient may be having associated volume overload, and it may be because of tricuspid regurgitation or a large volume of blood coming to right ventricle, right atrium. In the patient with ASD, blood flows from the left atrium to right atrium to the right ventricle. So a flow of blood into right atrium can result in
right ventricle.
Can give rise to what? Right atrial enlargement can give rise to right atrial enlargement. The atrium can be significantly dilated. So 2 reasons for right atrial enlargement are: 1, flow of blood coming to the right atrium, and 2, the blood regurgitating from the right ventricle. Okay, right? Yes.
And
Is the left atrial enlarged? Is there a left atrial enlargement?
there appears like a straightening of left heart border. Carina cannot be visualized properly.
No, straightening of the left border you should not describe. You should describe whether prominence of the aortic knuckle, prominence of the pulmonary segment, prominence of the left atrial appendage, and rest of the left ventricle. The rest of the cardiac ciliate. You don't describe straightening and all. That's not correct. That's only a visual impression. But that does not communicate to the examiner whether you know the importance of the left border of the heart. Left of the heart, the structures from above downwards are aortic knuckle, pulmonary segment, left atrial appendage, and rest of the left border of the heart is formed by the left ventricle. Okay, so here the pulmonary segment is prominent, and how will you make out whether what is the cause of this prominent pulmonary segment? How will you make out whether there is an increase in the pulmonary blood flow? How will you make out whether there is evidence of pulmonary hypertension?
Pulmonary vasculature.
Peripheral pruning, we have to see.
If there's a peripheral pruning with this one is centralization. The pulmonary vasculature becomes centralized. Central vessels are very large, but as you go to periphery, there is a sudden cutoff. That's a suggestive pulmonary arterial
Hypertension.
hypertension. Very good, yes. Anything else which can help you to diagnose pulmonary hypertension?
Dilated branch pulmonary arteries.
Yes, the pulmonary arteries will be dilated.
Endon vessels.
Endon vessels.
Endon vessels will not tell you about pulmonary hypertension. Endon vessels will help you to diagnose
Pulmonary plethora.
the shunt lesions. There is increased pulmonary plethora associated with the endon vessels, and that is suggestive of shunt lesion. Okay, in this patient, what do you think? Is there a endon vessels, or is there cutting off of the blood supply to the centralization of pulmonary arteries? What is happening? What is happening? How will you assess? What are the points by which you decide about the pulmonary blood flow? Pulmonary blood flow. Increased pulmonary blood flow is diagnosed by from the XHS by
The peripheral 1/3 also showing a lot of bronchovascular markings.
yes. If the vessels are can be easily tracked to the periphery of the lung field, that usually indicates increase in the pulmonary vascularity. Yes. What else?
Five or more.
Supplementation of the
Supplementation is a feature of cardiac failure.
5 or more endon vessels.
Yes, endon vessels. Look for endon vessels. If there is a 5, more than 5, 6 endon vessels, both sides put together, that goes in favor of pulmonary plethora. If there is a end on vessels equal more than how many numbers should be there on one side for us to diagnose plethora?
4.
4 or more than 3, 4 or more. If we have got 4 or more end on vessels, that also goes in favor of increasing the pulmonary blood flow. This is patient having end on vessel. You can see plenty of end on vessels. See, this is an end on vessel. It seems that there is an end on vessel. There is an end on vessel here. So this patient is having enough end on vessels. What do you mean by end on vessels? What is an end on vessel?
Vessels end phase, the projection of a vessel end phase.
Yes, the vessels are directed towards the, as you take the X-ray, the vessels are directed towards the X-ray beam or away from the X-ray beam. That qualifies for end on vessels. And when there is end on vessels, it will be seen as rounded, more prominent shadows compared to the surrounding structures, suggestive of end on vessels. This patient is having a beautiful end on vessel here. There's a good end on vessel here, and few end on vessels are also seen. What do you mean by peribronchial cuffing? What do you mean by peribronchial cuffing?
Edema around the bronchus.
Yes, there can be an edema around the bronchus that will result in
It will result in the size of bronchus when the bronchoarterial ratio increases.
yes.
Normally it's 0.85 in the upper zone, 1 in the mid zone, and less more than 1.15 lower zone.
Okay.
So if that ratio is altered, we can think of pulmonary plethora.
No, ratio can be altered in pulmonary hypertension without plethora. So the pulmonary plethora is diagnosed by one end on vessels more than 5, both sides together. 2, one side only more than 3. 3, the end on vessels can be traced, the vessels can be traced to periphery. And 4, there is a enlargement of the main pulmonary arteries, left and right pulmonary arteries can be enlarged. So these are the features of you diagnose the volume over end on vessels. End on vessels are the characteristic feature of increase in the pulmonary plethora. So is this patient having pulmonary plethora?
Yes.
Yes, this patient is a pulmonary plethora. When there is a patient is a pulmonary plethora, you have to find out whether it is a mostly a shunt lesion or whether it is a left to right shunt at the atrial level or whether it is a shunt at the left ventricular level or is it at the level of the main pulmonary artery or pulmonary artery. At which level? So it is ASD, VSD, PDA. How will you differentiate between ASD, VSD and PDA? In ASD, what is the chamber which can be dilated, which will not be dilated in VSD and PDA?
RA.
RA will be enlarged in ASD, but it will not be enlarged in VSD or PDA. What will be the structure which can be enlarged in PDA but not involved in other two lesions?
Aortic knuckle.
Aorta.
Aortic knuckle.
Ascending nerve.
Aortic knuckle goes in favor of PDA, and the presence of a large right atrium goes in favor of
ASD.
ASD. Right. So if either the right atrium is not enlarged and you are not able to see prominent pulmonary segment, then you have to go for VSD. So that is how you can differentiate between ASD, VSD, and the PD. Okay, what is this? Any volunteers? Somebody else can try. Access will be kept in the examination. You should be able to diagnose it without any difficulty. These are all classical X-rays, so you should not have any problem. Any one of you?
Chest X-ray PA view,
Just accept
well,
view.
well exposed and adequately centralized.
Okay. Maybe slightly underexposed, but okay, I will accept here. It is properly exposed, yes.
Emphysematous chest. Cardiac size appears normal.
Yes, cardiac size is normal.
The right atrium is not enlarged. The
Yes.
aortic knuckle is normal. The
Okay.
left Main pulmonary artery tongue appears dilated. LA appendage appears dilated. The LV apex
Yes.
cannot be
The
apex
main
cannot be.
pulmonary is dilated. You can very easily see the four structures which form the left part of the heart. This is the aortic knuckle, this is the pulmonary segment, left atrial appendage, and the rest of the left part of the heart. So it's very clearly you can see all the four structures which form the left part of the heart. Repeat: left the aortic knuckle, pulmonary segment, left atrial appendage, and rest of the left part of the heart. And this is formed by what?
Cannot be commented, sir.
It is not easy to comment, but if at all you want to comment, it's more like LV or more like RV?
RV, sir.
Why did you say it's RV?
More like LV, sir.
Yeah, more like LV. I would have thought more in favor of LV. You look at the angle here. You look at the angle between the cardiac cilia and the diaphragm. In a patient with left atrial, of course, left atrial cannot come here. With the sometimes it can come here. In a patient with left atrial enlargement, it is the angle between the heart and the left atrial, the angle between the heart and the diaphragm. You look at the angle, and the angle will be obtuse angle in a patient where the right atrium is enlarged, and if there's a left atrial enlargement, you can see the angle between the left atrium and the diaphragm will be an acute angle. Similarly, on this side, if the angle between the cardiac cilia and the diaphragm is acute angle, that will be more in favor of right ventricle. And if the angle is broad, is obtuse angle, or angle is around 90 degrees, that will be more in favor of a left ventricular configuration. And another is if the apex is dipping down, then you can be pretty certain that it is a left ventricular type of an apex. And if the apex is lifted up, clearly lifted up, that's definitely the right ventricular type of an apex. So these are the points by which you can see right ventricular type, left ventricular type, and right atrium, left atrium on the left side. Okay, right? Yes.
The RA is not dilated.
Yes,
LA,
RA is not. What are the criteria you applied to diagnose RA enlargement?
the width should, if it's more than 1/3 of the hemithorax, the RA
Yes,
is enlarged.
if you measure from the mid from the midline onto the hemithorax, if the right part of the heart extends beyond the 1/3 of the hemithorax, that is more in favor of RA enlargement. Very good. Yes.
If
Any
the
other
height,
point? Second is
if the height occupies more than 3 ribs and more than 2 intercostal space.
yes, equal to or more than 3 ribs or more than 2.5 intercostal spaces. That also goes in favor of
RA
right
enlargement.
atrial enlargement. Very good. Yes. Okay. Yes.
LA size cannot be commented, sir.
LSI is already LMS by enlarged because you have found
LA
that
must be
left atrial
enlarged. LA
appendage
appendage
is
is enlarged. Yes, sir.
enlarged. So there is an LA enlargement. Yes. What else?
Right pulmonary artery is dilated, prominent.
Which one? Pulmonary
Right.
arteries.
Right.
Okay. Pulmonary artery, not grossly enlarged, but maybe slightly enlarged, not very grossly enlarged. But what do you find this? What is this?
Upper lobe.
Yes, prominent upper
prominence
lobe
of the upper lobe.
vessels. Is it a vein or arteries which are prominent?
Veins, sir.
Veins. Upper lobe veins are prominent. When you talk about the upper lobe vessels, you are mostly considering the upper lobe veins. Upper lobe veins are very prominent. This is known as when both upper and lower, both right and left upper lobe vessels are prominent. Then it is also described as upturned mustache sign,
Yes, sir.
where it's so prominent that it can be seen as though the mustache is turned up. Okay, so that indicates pulmonary venous hypertension. What are the features of pulmonary venous hypertension in the X-ray chest? 5 features.
Upper lobe veins prominence.
Upper lobe
Presence
is
of
prominence.
curly B lines, curly A
Very
lines.
benign, very good.
Fisher effusion, pleural effusion.
But fissure effusion.
No, that is not a feature
Fissure
of
thickening.
pulmonary congestion. Sometimes you can get it. Mostly it is a feature of a right heart failure. What are the X-ray evidences of pulmonary venous congestion? You said 2, when the upper lobe vessels prominent, 2 curly B lines, 3,
Perihilar prominence.
perihilar cuffing,
Perihilar cuffing.
perihilar cuffing, 3, 4,
Chemocytosis.
Ground glass appearance. Sometimes there can be some interstitial edema. It can give rise to ground glass appearance of the lung shadow. And finally, frank pulmonary edema, the battering appearance. So here this patient is having, is the patient having is the patient having curly B lines? There are a few curly B lines. If you are very careful, can you see some lines here?
Yes, sir.
There are some curly B lines. Yes, very good. And you can see a peribronchial cupping. How do you diagnose peribronchial cupping?
There will be a dark
Central air shadow.
central surrounded by a
Around the central shadow, there will be whitish shadow. So here you can see a peribronchial cupping, very well seen here. Can you see here?
Yes, sir.
There is an area of peribronchial cupping. There is an area of peribronchial cupping here. There is a small area here. There is small, that's not good. So 1, 2, 2 or 3 areas where there is, you can make out the peribronchial cupping. So peribronchial cupping also suggests pulmonary venous hypertension. So the X-ray evidence of pulmonary venous hypertension are: 1, upper vessels are prominent, especially pulmonary veins. 2, the curly B lines. Curly A lines, C lines are also important, but it is easier to pick up curly B lines. 3, the peribronchial cupping. 4, ground glass appearance. And 5, frank pulmonary edema. Okay, right. Yes. So in this patient, upper vessels are prominent, curly B lines are there. And also there is a suspicion of a ground glass appearance. This area is definitely much more opaque compared to the lower area. So there can be some degree of ground glass appearance in the midsole. Okay, all put together diagnosis.
Mitral valve. This is probably a mitral stenosis.
Obstructed TAPVC.
No. What is the what will you find in obstructed TAPVC?
No stomach.
You can see something like a figure of 8 appearance. So you can see the vessels which come up and then go to the superior vena cava. You can see a large shadow here, which is suggestive of figure of 8 appearance. Here, this does not suggest at all. Here, patient is having mitral stenosis, significant pulmonary venous hypertension, and maybe mild pulmonary artery hypertension, not a very gross one, because the pulmonary, of course, pulmonary artery segment is prominent, but while the right pulmonary artery is not unusually large. So, but I will definitely agree with you that the patient is having some degree of pulmonary artery hypertension, pulmonary artery segment is large, and also evidence of pulmonary venous hypertension. Okay, so it's a case of mitral stenosis. What is this? Anyone of you? Anyone of you?
Chest X-ray peer view with well centralized film.
Okay.
Septus solitus.
Yes.
With LV type of apex. With normal aortic knuckle and left aortic arch. With prominent.
No, why did you say it's a normal aortic knuckle? What is your criteria? When will you say that aortic knuckle is prominent? What is the criteria?
I don't know, sir.
Oh, well, you should look at the transverse process of the vertebra. If the aortic knuckle is beyond the transverse process of the vertebra, then you will have to consider that it is aortic knuckle is prominent. So here, this is the transverse process here. You can see the transverse process somewhere here. So yeah, it definitely is beyond the transverse process of the vertebra. So this can be considered as a prominent aortic knuckle. Yeah. Okay. What else? What about the pulmonary artery segment?
MPA looks dilated.
Yes, MPA is dilated. Very good. MPA is dilated.
RPA, LA LA appendage normal, sir.
L appendage is not dilated. Very good.
And with the LV type of apex. And CT thorax, CT ratio is approximately 0.5.
Yeah, it is by visual assessment. It's about 0.5. Very good.
And right side branch PA looks absent.
Right side. You can see a large pulmonary segment here.
Okay, sir. That is PA, sir.
There's a right pulmonary is main pulmonary branch on the right side is hugely dilated, but there is a peripheral cutoff. See, as you
Yes.
you are seeing a big vessel here, but when you try to track peripherally, everything is cut off. But I agree with you that there is some relative or reduced blood flow onto the left side of the left lung. Okay, right. Yes. So why the pulmonary here? You have the large vessel here. What does it indicate?
Branch PA stenosis.
Okay, you can consider that there's a why do you want to say branch stenosis? You can say that this indicates a huge pulmonary artery, dilated pulmonary artery.
Yeah.
Anything else? What is this? What is this?
Calcification.
Calcification.
Where is the calcification?
Pulmonary artery, main pulmonary artery.
No, it's not the main pulmonary. You can see two parallel calcifications.
PDA, sir.
Yeah, PDA. It's a calcified PDA, and the PDA is extending from the pulmonary from the aorta somewhere in the posterior portion to the pulmonary artery, or near the junction of the pulmonary artery with the left pulmonary artery. So, what is the full diagnosis?
Patent ductus arteriosus with
Arteriosus. Patient has got definite evidence of X-ray wise there is a definite of pulmonary artery hypertension. So you can say patient has developed severe pulmonary artery hypertension.
Eisenmenger.
And calcified ductus.
Duct.
The ductus is calcified. So you can see calcified ductus here, prominent pulmonary aorta. You can see large pulmonary artery here. And if you consider that there is no, or you cannot see prominent in the left pulmonary artery, anything else which crosses your mind? If there is a peripheral stenosis of the peripheral obstruction or peripheral branch stenosis of the left side vessels.
Then syndromes.
Yeah, what syndrome?
Rubella.
Rubella, very good, excellent. Rubella syndrome. When you are thinking of the patient is having a PDA, and on top of that there is a right peripheral pulmonary artery stenosis, then you can put two together and think of the possibility of a rubella syndrome. Of course, this patient did not have rubella syndrome, but I think you should always consider that possibility, especially when you think that there is some reason to believe that pulmonary artery on the left side is not prominent and it can be even stenotic. So it's a case of PDA, calcified PDA, and you can see that there's evidence of pulmonary hypertension. This patient had actually gone in for Eisenmenger syndrome. What is this shadow?
AV group calcification.
AV node calcification. AV node is a small area. Why should it have such extensive calcification?
Mitral annular calcification.
Yeah, very good. It's a case of dense mitral annulus calcification. Dense mitral annulus calcification. Yes. What is this?
Heterological.
Beg your pardon? What did you say?
No.
How is the apex in this patient?
Upturned.
Upgoing, sir.
Upwards. So this is actually, you can see that from the apex, if you trace the cardiac fillet, it goes and meets the diaphragm at an acute angle. Suggestive of excessive.
RV.
Yes, suggestive of tetralogy of hello.
And
And reduced pulmonary pressure. All features are there. And aorta is prominent. Yes.
So this is
chest X-ray, AP, situs solitus.
cardiomegaly.
Yes, very good. And that's
Cardiomegaly with probably pulmonary edema.
This is a suspicion of ground glass appearance. Okay, I agree with you. Yes.
It's a neonate, so it may be obstructed TFPC.
Why do you say what is
Narrow
it?
pedicle.
Narrow pedicle. The pedicle is very
Okay.
narrow. The narrow pedicle does not go with the.
Okay. Obstructive.
Does not, it does not go with the total nervous pulmonary venous drainage. TPVC. No, wrong.
TG.
So whenever there is a, what are the conditions which you get in narrow pedicle?
Abstinence.
Abstinence, very good.
TG.
PG.
Transpositional great arteries. Because in transpositional great arteries, two vessels are placed anteroposteriorly that can increase the narrow pedicle. And in this is a baby, about I think 1 month, less than a month. And the very usually there will be a diaphragm, there will be a thymus will be here, and thymus disappears by the age of 6 months to a year. It goes up to sometimes even up to 2 years. It actually provides the immunity. So the absence of thymus shadow usually indicates a very serious congenital heart disease, and the commonest condition where there can be a narrow pedicle and also the absent thymus is transpositional great arteries.
Yes.
So here this patient is having endon vessels. You can see endon vessels, narrow pedicle, and significant cardiac enlargement. You can think of the possibility of transpositional great artery. Okay, what is this?
So this is PA view, chest
Okay.
X-ray, well centralized,
Yes.
well exposed. Then RA is not enlarged.
Okay.
Aortic knuckle is okay.
In the examination, you should actually come to the most salient point and discuss that. What do you see? What?
Sir, there is calcification in
Yes.
left ventricle.
Yeah,
which
very
is
good. That's a calcification of the left ventricle, a large area of calcification.
enlarged.
And this type of calcification in left ventricle can happen in patients with
LV aneurysm.
LV aneurysm, post-infarction LV aneurysm. So this is a case where the patient had an LV aneurysm and had a calcified aneurysm of the left ventricle. So this is a calcification involving the death tissue, and that disease is not functional. Okay, right. Yes. Okay, analyze the cath data. Any volunteers to analyze the cath data?
Yes, sir. SVC saturation, IVC saturation is normal.
Okay.
And right atrial, higher right atrial is normal. There is a step up with there is a step up from the right atrium to the RV.
Is it significant enough to call it as a step up? What is a step up seen here?
Only 4. If we consider it's only 4, sir.
The step up is only 4. So 4 is not enough. What is the step up required to diagnose? 5 or more. The ventricular, can you tell me from the atrial level to the
755. 755. 7 at atrial level.
Okay, 755. Single sample, multiple samples.
Single, multiple, different.
Is it single sample or multiple sample?
Single sample.
No, it's multiple sample.
Oh.
755 is multiple sample. Single sample is
10
10,
to 11.
10,
9,
10 to
6.
11, and 7.5 or more, 7 or more, and in the pulmonary artery it is 5 itself. So the step up can be considered in the form whether it is a.
Sir, in single sample, how much, sir?
I will repeat again. Single sample, atrial level 10, ventricular level 7, main pulmonary artery level 5. Repeat. If the step up is more than 10 on the atrial side, more than 7 in the ventricular side, and more than 5 in the arterial level, single sample is enough. When it's multiple samples, it can be 7 for atrial, 5 ventricle, 5 for pulmonary artery. So it is 7, 5, 5 multiple samples, 10, 7, 5 for single sample. Okay, is that clear?
Okay, thank you, sir. Yes.
Now, pressure data, somebody should analyze. Somebody has started already. Continue.
RV systolic pressure is high. RA pressure is normal.
No. You are not mentioning about where is the shunt. Is there a shunt here?
No shunt.
What is the mixed oxygen saturation?
Shunt, shunt is at the level of high right atrium to mid right atrium.
No, there's actually, what is the mixed venous sample in this patient?
Okay. So whether we should take high SVC or low SVC for mixed venous?
That's not matter. You can choose. Anyhow, you take it midway between. You take it 67.
Okay.
And IVC is
70%.
21.
4 into
It is 68.
So difference is 4. 4 divided by 4, so it's
68.
1. 1. So you add 1 to the SVC. So 67 plus 1 8. So take it as 68. 68% would be the mixed venous oxygen saturation. From there, what happened to the mid right atrium?
Oh.
84. So step
84.
up significant.
No step up. So indicating that there is a
Left to right shunt.
saturation at the atrial level.
atrial level.
There are prominent torrential left right shunt at the atrial level. Okay, right. Yes. Is there any step down anywhere? No.
No, sir.
Okay, right. Yes. Pressure data.
RA pressure and LA pressure same, suggestive of a non-restrictive ASD.
Okay.
Then RV pressure is increased.
You should say that your LA pressure is not here.
Atrial shunt.
Pulmonary artery
Systemic
wedge pressure.
pressures are not recorded, sir.
No, pulmonary artery wedge pressure is there.
Okay, yes. Actually, there should have been left atrial pressure, but due to some reason it was not recorded because the left atrial oxygen saturation is there. Okay, right. Yes. Pressure data. You tell me the pressure data. Right ventricle.
Right ventricular systolic pressure is elevated. Diastolic
Elevated.
pressure is normal.
Very good.
Pulmonary artery, both systolic and diastolic pressures slightly high.
No, the 30 can be taken as upper limit of normal. 12 upper limit of normal. 20 also is upper limit of normal. 20 may be abnormal, but if at all you can say mild pulmonary hypertension. Yes. Is there a gradient across the?
Gradient is there, sir. RV to PA gradient.
There's a gradient across the RV outflow. What does that mean?
Maybe infundibulary stenosis or pulmonary stenosis.
Okay, well, you cannot be better be diplomatic whether there's a gradient across the RV outflow. Whether the gradient 15 gradient is it enough for you to diagnose a RV outflow obstruction?
No, it should be more than 25.
Yeah, usually the gradient should be equal to or more than 20. 20 you can take it as abnormal. Some people have found that in patients with torrential left to right shunt, sometimes the gradient across the pulmonary artery pulmonary valve can be as high as 30 to 40 millimeters, and still there may not be any obstructions. So when mixed with a very good pulmonary blood flow, a gradient of about 15 millimeters may indicate that it is because of the increase in the pulmonary blood flow, and by itself may not indicate a separate pulmonary or RV outflow obstruction. Okay, right, go ahead.
QP by QS is 3.
QP by QS is 3. Is it 3? Where is the, you tell me the formula?
Aorta minus mixed venous divided by LA minus pulmonary artery.
Okay, right. So mixed venous is 68 or 67, 68 or 68, and aorta is 98. So it's 40. So 30.
30 divided by 9, around more than 3.
Main pulmonary is 90, 9. Okay, right, 9. So 90 more than 9 divided, so it will be around almost more than 3.
More than 3.
Okay, right. Very good, excellent. You did very well. What is your name?
Ranjit.
Oh, I think you are very good. I think you are answering most of the questions. I think you have been trained well. Good, excellent. Somebody else can try this. 3-month-old male baby. Somebody else can try. Seniors.
So pulmonary artery saturation is less than aorta saturation, so it's not a transposition. Then
You're going in a very unusual pattern. Okay, right, yes.
yes, sir. Then SVC, IVC is 70. Mid RA is 71. Lower RA is 70. There is no step up or step down. RV is 71, 70. So no step up, that level. Pulmonary artery is 76. Step up of 6. So it's elevated, sir. Step up is there.
Very good, yes.
Then LA is 94, LV 94, aorta 94. So there is no step up or step down there. So there is step up at the
LA 94 is it normal?
LA saturation of LA 94 is step down, sir. Then
there is not step down. There is some degree of desaturation.
Desaturation is there.
You do not know whether it is really step down or desaturation. What is the difference? Step down is because of a desaturated blood reaching a chamber where the oxygen saturation from the previous chamber to the present chamber is down. For example, if there is a right and left shunt from the left right ventricle to the left ventricle, desaturated blood is reaching the left ventricle. And if the oxygen saturation in the pulmonary aorta left atrium is 98 or 99, and then the oxygen saturation in the right, the left ventricle is 92, then we know that there is a right to left shunt.
Right to left shunt.
Yes. So here it is 94, 94, 94. There is no step down, whatever we can make out. But the oxygen saturation is definitely on the lower side.
Lower side.
Okay, right. Yes.
So
what is your diagnosis?
In pressure, sir.
Okay, pressure.
RA A is 8, V is 9, mean is 7.5.
Okay.
Normal.
Normal. Okay, right. Or maybe B wave is slightly on the higher side. So the B wave is A and B wave in the right atrium is up to 8 millimeters. So it is 9. So borderline elevation. Right. Yes.
Yes. RV is 60, which is elevated.
Okay.
Step up pressure. So there is then PA is same, sir. Systolic is same, 60,
Okay.
60.
Okay.
Diastolic in PA it is 25.
Okay.
Mean is 40. It is so RV PA are elevated.
Okay. RV pressures
Pulmonary
are all
artery
elevated. Okay. And pulmonary artery pressures are also elevated. There's some degree of
elevated.
moderate pulmonary artery hypertension. Okay, right. Yes.
LA is 18 and 23 elevated.
Okay.
LV is 85.
Okay.
So there is again step.
Eh?
LV is 85, sir, systolic, diastolic 18.
Oh. So there is a
And,
significant elevation of the LV.
Pressure, systolic pressure.
Diastolic pressure. No,
Diastolic pressure. Diastolic pressure.
Normal LV diastolic pressure can only go up to 10 or 11.
10 or 11.
It has gone to 18. Yes, okay.
Aorta is 90/50.
Okay.
So
Patient is having there is an oxygen step up at the pulmonary artery level.
pulmonary artery level.
Yes. And there is
So,
a desaturation in the LA, LV, and the pulmonary artery. So you have to explain two things.
one I can think of ventricular septal defect.
Yeah.
PDA.
What did you say?
No.
Did you say ventricular septal defect?
Yes, sir. Yes.
Did you say left ventricular septal defect?
Yes, sir. Yes, sir.
Yeah. So how can it be when there is a ventricular septal defect? There can be oxygen step up at the pulmonary artery level.
Pulmonary.
What are the conditions in which you can get oxygen step up in the pulmonary artery level?
PDA, sir. PDA.
PDA and
PDA.
AP windows.
AP window. So you have to consider AP window as an important possibility because it's a small child and has come with significant symptoms and there is oxygen desaturation in the left side chambers. So I think you should consider possibility of AP window.
AP window.
Potential flow. Okay, right. Yes. What is the reason that she's having this desaturation?
Eisenmenger.
Not Eisenmenger.
Pulmonary edema.
Yes, the patient is having significant.
Pulmonary edema.
Patient has gone in for LV failure and has got even the
Endostolic volume is elevated.
LV and diastolic pressure is 18.
Pressure is 80.
Everything is elevated. And so that may be the reason the patient may be having interstitial edema. And that may be the reason that the patient is having a deoxygenated blood in the left atrium, left ventricle and the pulmonary artery. And most likely this is a small child and the patient is presented with the features of significant heart failure. So I have to consider a possibility of AP window with a torrential flow rather than PDA. PDA, of course, large PDA can have such a situation, but I would prefer you to make a statement that in view of the early symptoms, early pulmonary congestion, and early evidence of left ventricular failure with a significant elevation of the LV diastolic pressure, more likely possibilities AP window rather than patent ductus arteriosus. Okay, how will you calculate pulmonary blood flow, systemic blood flow, and pulmonary vascular resistance? What is pulmonary vascular resistance? How do you calculate? What is the formula?
QP into body surface area.
One second. Okay, yes, go ahead.
Resistance is pressure by flow.
Yeah, it is pressure by flow. Not pressure by flow, pressure drop by flow.
Okay.
So what is the formula for pulmonary vascular resistance? What is the pressure drop?
Pulmonary artery pressure, mean pulmonary artery pressure minus
mean LA pressure.
Yeah. So here what is the pressure? PA mean pressure is 40 minus
20.
20. So it's 40 by minus 20 seconds, 20 millimeters.
20
Then
by QP.
we have to calculate the
QP.
pulmonary blood flow. So what is the formula for pulmonary blood flow?
Oxygen consumption divided by oxygen content into.
Not oxygen content, oxygen difference. Arterial oxygen difference, not content. Arterial oxygen difference, yes. So here, tell me the formula that is enough.
So VO2 upon hemoglobin into 13.4 into
13.6 into 10
aortic
into
aortovenous oxygen saturation.
No, I could not get you completely. Can you repeat it?
VO2 divided by PV minus PaO2 into oxygen content.
Oxygen.
Oh, okay. That will tell you the
QP.
QP. Okay, yes. The QP is calculated from the formula oxygen consumption divided by arterial oxygen difference. That will give you the pulmonary blood flow. So here, what is the oxygen consumption? 85 ml. What is the arterial oxygen difference? You have to calculate the arterial. But we are getting the oximetry. From the oximetry, you have to convert it into oxygen content and oxygen utilization. How will you convert this into oxygen content?
Hemoglobin into 1.34. Oxygen carrying capacity of
1.3. Actually, this is 1.36.
36.
1.34 will give you exactly what is the oxygen carrying capacity of the hemoglobin. But some oxygen is dissolved in the plasma also. If you want to include that, you can multiply it with 1.36. Okay.
1.3.
So that will give you also oxygen saturation in the arterial blood minus oxygen venous blood. Here it is actually
venous blood.
The left atrium is 94 and the pulmonary artery is
76.
76. So you can calculate the okay, fine, great. We'll go to next one. Good. So you know it. Get data.
Here, PA saturation is less than aortic saturation, so no transposition.
Why do you want to go like that? You have been taught to say like that. See, what are the conditions in which PA saturation can be more than aortic saturation?
TGA.
TGA. What else? What are the conditions you can get? Yes.
TAPVC. Sir.
Yeah, TAPVC of the supracardiac variety. Yes. One more.
Subpulmonic DOR with subpulmonic VSD.
Yes. It's known as
Toxic being anomaly.
Toxic being anomaly. So these are the three conditions in which you can have oxygen saturation in the pulmonary artery more than the aorta.
Aortic.
I don't agree to the point of saying that since the pulmonary artery oxygen saturation is less than that of the aorta, it is not transposition.
Yes.
Okay.
Yes, I guess.
Systemic blood pressures are 105 by 75 with mean 85, sir. Normal. RA pressures are A is 10, B is 8, slightly elevated.
A is slightly
elevated. Yes, sir. And RV pressures 45 by 6. That is RV systolic pressures are elevated. And pulmonary artery 45.
No. You have to mention whether is there a gradient across the tricuspid valve?
It's 2 millimeters. That may not.
2 millimeter. Or if you look at the A wave, there is a gradient is
4.
4. 2 is enough. In the gradient up to 1 is can be passed off without any comment. But if it's 2 or more, it is stenosis. What is the gradient level which will tell you about is it significant obstruction? Mean gradient across the mitral valve, tricuspid valve, pulmonary valve, and aortic valve.
Mitral valve, any gradient is
Any gradient is
significant.
No. Up to 2 can be taken away. Mitral valve mean 2, but tricuspid valve mean 1. If it's more than 1 is abnormal. In pulmonary, in the mitral valve, more than 2 is abnormal. And the gradient across aortic valve, gradient across the pulmonary valve,
20.
15. 15 on the aortic valve and pulmonary valve.
20.
20. No.
10.
The pulmonary valve is much, yes, about 6 to 8.
22.
So it is on the systemic side up to 15 is all right. Aortic valve. On the pulmonary side, less than that. Very often it is only about less than 10. Okay, right. So there is a gradient across the.
RA to RV gradient of around 4 millimeters of mercury.
Okay.
Yes, sir. And PA pressures are 45 systolic. No, with mean of 30. So mean pressures are elevated.
Okay.
There is no RV to PA gradient.
Very good.
And PA pulmonary artery wedge pressure is 16 millimeters of mercury.
Okay.
Normal, sir.
Okay.
So
is it normal or
slight?
Normal? What is the normal?
10 to 12.
Yeah, 10 to 12. 10 or 11. 11 even is, or if you are looking at pulmonary artery valve, you can go up to 12. LA pressure is 10 to 11. And when you think of the pulmonary artery valve pressure, it can be 1 millimeter extra. So 16 is abnormal, it's elevated.
Yes.
Which A wave is 18, B wave is 14. So there is a main pressure is 80, 16.
80.
So the pulmonary, the left side pressure is not significantly, but there is a mild elevation.
Mild elevation.
Yes. Gradient across the mitral valve.
Gradient of 6. Gradient of
Gradient of 20.
10.
10, at least 10. Okay, right. 10, yes, right.
Yes. And aortic pressures are 105 by 75. The LV to aorta gradient of around 25 millimeters of mercury.
Okay. So
Gradient of-
significance. Up to 15 can be, 15 can be, what is the significance? Up to 15 can be taken off as, passed off as normal. More than 15 is borderline. Borderline. Okay. So what is your diagnosis?
Sean complex.
Why did you say Sean complex?
Multiple stenotic lesions.
25-year-old female multiple stenosis. What should be your diagnosis?
Rheumatic heart disease.
Rheumatic heart disease. So you can, this patient has got evidence of pulmonary mitral stenosis, tricuspid stenosis, and I don't know whether there's
aortic.
also there's some degree of aortic stenosis also. So it's a rheumatic heart disease, mild stenosis, mild mitral stenosis, mild tricuspid stenosis, mild aortic stenosis. For the oximetry data, nothing special. Okay, I think that is enough now. I think already 9:05. Or will you just take this as the last one? Any volunteers? Let us discuss the last one.
SVC.
SVC saturation 60%, sir. IVC 64. RA 61. No step up or step down. RV 62. No step up or step down. And PA 70, sir. There is a step up of around 8%. And
Why did you use the word around? It's 8%.
It's 8. Yeah.
Don't use the unnecessary. Don't use unnecessary words. From the data provided, there is an 8% step up at the pulmonary artery level. Yes.
Okay. Pulmonary artery wedge pressures, wedge saturation 99% normal, and LV saturation is 86%. There is significant step down of 13%. Sir.
Very good.
And aorta saturation 85. Decreased.
Okay.
So RV to PA step up.
Okay.
And PA to LV step down. Sir.
Very good. Yeah, PA to LV.
I mean LA to LV, sir.
PA wedge to LV. Yes.
Wedge to LV.
Yes, okay. Yes. Okay, you have to look at the pressure data before we draw any conclusions. Yes.
Yes.
Pressure data.
And, sir, systemic pressures are 120/70 with mean of 84 normal, sir.
Okay.
So with RA pressures are mean 8 normal.
Okay.
With, A equal to V, sir. And RV pressures are inflow pressures are 120/8, sir.
Okay.
There is no RA to RV gradient, but there is a significant increased RV inflow gradient.
Okay.
And outflow gradient is 58 systolic with mean of 8, sir.
Okay.
There is
a gradient
2 millimeters of inflow to outflow gradient.
Yes, there's a gradient, significant gradient between the RV outflow and inflow. Okay, very good.
Yes. And PA pressures are 40 systolic with mean of 25, sir. Elevated.
And also there is a gradient across the
RV outflow to PA. No, yes, sir. RV outflow to PA of 18 millimeters of mercury.
Okay, very good.
And wedge pressures are normal, sir.
Okay.
And LV pressures are 120/8.
Okay.
And RV inflow pressures are equal to LV pressures.
Okay. Which are the pressures which are equal?
So RV, LV, sir.
And
RA and wedge pressures.
No. The pressures are
RV equal
RV, LV, aorta.
RV, LV, aorta. And what is the condition in which you get equalization of pressure RV, LV, aorta and pulmonary artery?
Overriding of the aorta in top.
No. What is the condition in which you get systolic pressure in the RV, LV, PA and aorta the same?
VST, large VST.
Large VST with? When they have gone for Eisenmenger syndrome.
PSG, PS physiology, sir.
There is no need of going for when there is a PS physiology, what will happen to pulmonary artery pressure?
RV to PA grade.
The question I asked was that what is the situation where you can have equalization of systolic pressure of the RV, LV, aorta and pulmonary? So the answer is VSD Eisenmenger. Here the pressures of the RV systolic, pulmonary, the LV systolic and the aortic systolic are the same. The condition in which you get all the three pressures are equal is
overriding of aorta.
No, aorta need not override. Tetralogy fellow.
Tetralogy fellow.
Tetralogy fellow is the condition where you can get equalization of systolic pressure of the RV, LV, and aorta. Right. Okay. Yes.
Gasolization is possible, sir, in this case. Gasolization because there is an RVOT gradient.
That you see, it is impossible to differentiate because it's a 12-year-old female. Too early for the patient to develop gazole VST resulting in tetralogy fellow-like situation. I would consider more likely that it is tetralogy fellow. But if you want, you can discuss that possibility also that this patient might have had a large shunt or a moderate sized shunt. On top of that, she has developed a pulmonary stenosis and now she is presenting similar to tetralogy fellow. Okay, right. Yes. So what is the diagnosis?
Tetralogy of fellow.
In tetralogy of fellow, what is the pulmonary artery pressure usually?
Normal.
And what is
pulmonary it is elevated.
It's elevated. What is the reason?
Top with pulmonary peripheral pulmonary artery stenosis.
Peripheral pulmonary artery stenosis. Do you have evidence of peripheral pulmonary artery stenosis? Is there evidence of nothing? No evidence has been given to you.
This can be AVSD because there is a shunt.
Yeah, there is a shunt. So how can what can be the shunt there? It can be a man-made shunt.
Yes.
When there is a man-made shunt, there is a possibility that very often if it is a central man-made shunt, that is a port shunt or a water shunt, gully shunt, the flow to the pulmonary system may be so large that the patient can go in for pulmonary vascular reaction and they can have pulmonary arterial hypertension. So in this patient, most likely might have received a central aortic shunt, which has resulted in elevation of the pulmonary artery main pressure as well as pulmonary vascular resistance going up, and that may be the reason that patient has got an elevated pulmonary artery pressure. So this is a case of pathology of fellow, elevated pulmonary vascular resistance, secondary to large left right shunt, man-made shunt, most likely a central shunt, either a water shunt, gully shunt, or it could be a port shunt. Okay, I think that's enough. We'll stop at the 11. Next week, I have got an engagement. So please find out whether I am available or not, because I have got an engagement. If there is, you can contact at about 7 o'clock. If I am available, I will be taking a class. But if I am not available, then tomorrow, next week, there won't be any class. And the next discussion will be a case discussion. We will have a case discussion either next week or the week after next. Okay? Right.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Good night.
Thank you,
Good
sir.
night, sir.
Good night.
Thank
Hello.
you, sir.
Hello, Priya.
Thank you, sir. So with the permission, shall we conclude this
Yes,
meeting?
yes, we can conclude.
Thank you, sir. So from here now, I'm ending this meeting. Good night, sir.
Good night.